Hello, everyone. Welcome back again. This is PT Forensics, episode number 4. Man, we're just rolling along here. So today, Corey and I will be discussing cervical radiculopathy. So for some of the people out there who are listening who may not be practitioners or clinicians, essentially what that is in a global sense, it's when you have neck pain and you got that numbness tingling going down your arm. So a lot of you out there listening may be very well familiar with this if you are a clinician, as well as if you actually have it. So hopefully we could give you some good information. We're going to break down some research as always. We're going to go over a patient case as always, and then tie it all together at the end. So without further ado, I will bring in Corey and he'll discuss the patient case for today.
Thanks a lot, Dave. So I took another one of my patient cases that I think is pretty universal across a lot of outpatient orthopedic clinics. We see it really commonly, and there's probably different factors that go into why we see it so commonly. But so here we go. The patient case is a 52-year-old female. She works as an administrative assistant and has recently developed some left-sided arm pain. This pain is worse as she sits at her desk and she types and answers phones all day long. She's been having a lot of difficulty sleeping because of this pain. She has trouble laying on both sides and on her back. She reports that the pain extends to the top of her shoulder, her lateral arm, and down the outside of her lower arm on the thumb side. She has intermittent tingling into the outside of her lower arm on the thumb side again. And when she sits and works for too long, she develops a headache in the base of her skull. And that can kind of refer over to the top of her eye. Upon your observation as a therapist, you noticed that the patient's resting, standing, and sitting posture are characterized by a classic upper cross syndrome. Again, if you're not a clinician, basically we're looking at big time, those shoulders are coming forward. You can see that the pec muscles are nice and tight in the front, and her shoulder blades in the back have kind of rounded around to the front. And that the forward head posture, where that head is kind of jutting out forward ahead of the rest of the body. And you can see everything in the base of her neck is a little bit cramped up, a little bit gummed up back there.
Right, and I just want to jump in. If a lot of you are sitting right now listening to it, it's probably the posture that you're in right now.
Right, 100%.
So as we're discussing this, I'm sure a bunch of people are like correcting their posture, sitting up a little bit taller, but that's what essentially Corey is talking about right now.
Yeah, totally. And you can feel how that gets uncomfortable and how you might have to move out of it. And then think about if you have to do that for 8 hours a day, right? Mm-hmm. And maybe as this patient, she's on her phone, she's typing, her hands are extended in front of her, and maybe she has that classic phone in between her ear and shoulder, where now she's cranked up with a nice upper trap shrug. And you can think of what's going on in the neck there.
You got to get that work done, I guess, but we're getting some issues.
That's right. All right. So with this, I kind of wanted to go into one of the bigger collections of research we have in regards to the neck, and that was the neck pain guidelines that were put out the American Physical Therapy Association and the Journal of Orthopedic and Sports Physical Therapy. So they do this periodically with different diagnoses. They come up with a clinical practice guideline. They try to take the best evidence and determine, how should we really be treating those folks. So the original neck pain guidelines were done in 2014, and this was an attempt to fit those patients. 2008, and they were attempted to fit those patients into categories based on symptom behavior and special testing, and they wanted to help determine what the best treatment for these patients would be. So they basically came up with a handful of categories for neck pain patients. You can either be in a neck pain with mobility deficit category, neck pain with movement coordination impairment, neck pain with headache, and neck pain with radiating pain. And neck pain with radiating pain is what our patient is going to fall into. She has neck pain, and it travels down the arm in the form of pain and also in the form of numbness tingling. We're not going to go into all those different categories today because based on our patient case, we're looking at cervical radiculopathy. And I'm also not going to go crazy into this guideline because it is an 83-page guideline, and the details get very, very specific. So basically, I just want to let you know the ratings, they rate their evidence that they include 1 to 5, and then they grade their recommendations A to E. So they're basically using our standard hierarchy of evidence, with expert opinion kind of being at the lowest end, systematic review meta-analysis being at the higher end, the higher quality evidence. All right, so I just want to pull out some of the important points here. The first thing I want to bring out is some of the evidence they looked at in regards to prognosis. Now, they found moderate to high-level evidence, which is rare in physical therapy world, but moderate to high-level evidence indicating that female sex and or prior history of neck pain are consistent risk factors for new onset of neck pain. Cause of that is, I don't know, that's kind of hard to discern why females tend to have a higher risk than males, but prior history of neck pain is also a consistent risk factor for an onset of new neck pain. They had low to moderate quality evidence suggesting that older age, high job demands, being an ex-smoker, low support, and prior history of low back pain may also be risk factors. And then back to some moderate and high level evidence indicating that clinicians should collect and consider pain intensity, level of self-rated disability, pain-related catastrophizing, and post-traumatic stress symptoms. And again, this is probably a discussion for another day, but this goes into the importance of all those psychosocial factors that come into it. What are your patient's beliefs about the pain that's going on? And Dave, I think something that I don't know if I'm starting to see it more regularly or starting to recognize more regularly, is that pain catastrophizing.
Yeah, definitely. It's actually one of the, when I go into my article, it's one of the things that they look at. It's actually, well, there's pain catastrophizing, yes, but there was also kinesiophobia, so just fear of movement as well. So bringing that psychosocial aspect into it is a huge part that I agree with you. I'm starting to recognize more as I get some more hours under my belt as well.
Absolutely. I'll let you delve into a little bit of that in your article. So that's it for prognostic stuff. We have a nice section on diagnosis, and again, this is kind of a little bit of an overview. I want to give a quick direct quote here. In the article, they say that direct pathoanatomical causes of mechanical neck pain are rarely identifiable. Not an awesome thing to hear as a clinician or as a patient, but we understand, or I guess we lack to understand, what exactly is causing neck pain in just general mechanical neck pain. And it goes on to state that clinicians should inquire and test for clinical findings in patients with neck pain to help determine the potential for the presence of serious pathology. So again, the nice thing is, as someone, Dave and I, who work in direct access states, we might be seeing these people as a primary entry into the healthcare system. So we as clinicians should be able to identify when there's some sort of serious pathology going on, such as infection, cancer, cardiac involvement, or maybe you just need to refer out because you're worried about a fracture or something like that, a dangerous mechanism of injury. So again, clinicians should be alert and be alert for and assess patients for signs and symptoms of serious pathology. Another one of those being the suspected arterial insufficiency. We don't have great tests for that, but we have tests for that. And again, we can probably talk all day about this kind of thing, but when it comes to cervical manipulation, looking at those cervical artery tests, and to me, just as important is looking at vital signs. Dave, I know that's an interest area of yours.
Yeah, I mean, it's something that I've sort of seen recently. There's a PT named Rich Severin. He mentions a lot about taking vital signs, and if physical therapists want to be in this direct access kind of role, then I think we need to start taking vital signs a little bit more frequently, especially in patients that seem a little bit on the edge there of whether they have some sort of medical comorbidities going on or something of that sort.
100%. And to me, in this patient case especially, this patient's got a headache. Now, based on the way they present, it sounds to me like kind of just a suboccipital headache referral pattern. But to be diligent, I agree. I really think we should be taking vital signs on more people. All right. So again, these guidelines go into talking about what we should be doing to screen out those folks with serious pathology. We all know our red flags for things like cancer, an infection and things like that. But I just want to quickly review our rules for radiography. As physical therapists and as clinicians in general, we have the Canadian C-spine rules, the Nexus rules, and the American College of Radiology recommendations. Those last ones are pretty long, so I'm just going to quickly review our Canadian C-spine rules and Nexus rules. The Canadian C-spine rules are if the patient is over 65, or if they had a dangerous mechanism, so high-speed crash, or if they have paresthesia in their extremities, then you should get an X-ray. Again, more so if you're that primary person seeing the patient. If they already went to the ER, they most likely already went through all these rules here. If they have any of these following factors that represent the ability to safely examine range of motion, then you could check range of motion. These factors are the absence of posterior midline cervical spine tenderness. It was just a simple rear end collision, so a person just got in a fender bender. If they're ambulatory at any time, if they're sitting in the emergency room, or if they have a delayed onset of neck pain. So if they have any of those factors, you can go ahead and safely examine their range of motion. Now, if they don't have any of those factors, then they should get an X-ray. And also, the last part of those C-spine rules is if you examine the range of motion and it's less than 45 degrees in either direction, an X-ray is warranted. And then quickly, the Nexus guidelines, they are as follows. And again, you can Google any of these ones here. If the patient has all of these following factors, no posterior cervical spine tenderness, no evidence of intoxication, normal alertness, no focal neurological deficit, or no painful distracting injuries, then no X-ray is warranted. Right? So again, it's easier to look at in a little bit of a table, but if they have any of those factors, an X-ray is warranted. I know I'm laughing looking at the intoxication one. I don't get many intoxicated patients in PT. Again, these are more emergency room guidelines, but they are good to know as a physical therapist, especially in primary care. All right, and then lastly about diagnostics I want to talk about is, as physical therapists, how are we identifying these patients with cervical radiculopathy? The test item cluster that is still advised by the neck pain guidelines in both of these, in the original and in the update, is a positive Sperling's test. The Sperling's is ipsilateral side bending, right? So if the person's got right-sided pain, you're going to side bend to the right, and you're going to give axial compression straight down from top to bottom. And you're looking to see if you reproduce those symptoms. That's another test, Dave, where I'm asking them, where are you having that pain?
Exactly. Point to it.
Right. So again, that test item cluster is a positive Sperling's test, a positive upper limb tension test, and there's different variations for different nerve patterns. A positive distraction test where you're lifting off and trying to give relief to the compression of the cervical spine, basically in the opposite direction of the Sperling's, and checking range of motion. Right. So you're using those 4 tests to put together, are you looking at a patient who has cervical radiculopathy? Now again, it also advises, and I would totally agree with, they state that it should also be associated with the sensory, motor, or reflex deficits that you find. Again, our patient case will go into towards the end, but they have kind of a classic referral pattern of a certain level. All right, now just to quickly touch on treatment, because Dave is going to get more into treatment than I am. The neck pain guidelines don't really give super strong evidence suggestions. They haven't changed much since 2008, and they basically came right out and said that we've had little advancement in our knowledge of treatment of this group of patients since our last guideline, since 2008. And again, Dave and I were talking a little bit before. I think it's probably due to research methodology problems, right? Like, how are we identifying exactly what type of patients we have in the studies? A lot of the studies we're finding the patients that are included are not a homogeneous group, so there tends to be a little bit of heterogeneity between them. Again, I'll let Dave get a little bit more into that. Just to wrap up the guidelines here, first of all, the diagnostic groups that we talked about: neck pain with mobility deficit, neck pain with movement coordination impairment, neck pain with headache, and neck pain with radiating pain. Those we're giving with a recommendation of C, right? A, B, C, D, E were our ratings there. They were given a C. So we're trying to put people into these nice, clean groups, but unfortunately, it's not as easy as it sounds. And so what they gave for patients with radiating pain, they gave a level C recommendation for immobilizing or stabilizing exercise, low-level laser therapy, and short-term use of a cervical collar and acute neck pain. Now, I actually, with that level C, I did a little bit of digging. The low-level laser articles that I saw were generally had some statistical significance, but not meeting any minimally clinically important differences there. There was some evidence for use of a short-term collar and acute neck pain. Again, not the strongest recommendation. For chronic neck pain, though, they had a level B recommendation for the use of intermittent cervical traction, combined with other treatments such as manipulation or mobilization, stretching, strengthening, and, among others. So that basically, again, there's a ton in these guidelines. They are worth a read if you're a physical therapist. They're good to get used to and to get a lot of those things solidified in your mind. But with that said, Dave, let's hear from your article.
Awesome. Thank you, Corey. So going into my article, it is from Julie Fritz et al. From 2014 in the Journal of Orthopaedic and Sports Physical Therapy. Now, hold on, everyone. We got a little bit of a long title here, so get ready for it. The title of the study is Exercise Only, Exercise with Mechanical Traction, or Exercise with Over-Door Traction for patients with cervical radiculopathy with or without consideration of status on a previously described subgrouping rule. Whew, that's a title right there. So essentially the purpose of this study was to determine the ability of cervical traction to improve clinical outcomes when added to a standard exercise program in specific groups of patients with neck pain. Now, one of the issues I have with this study is it doesn't really go deep into what this standard exercise program is, which I think in general is actually one of the problems that we're having in physical therapy research right now. Is that a lot of these studies, they talk about exercise in this or exercise in that, and they give some prescription as far as how often and duration, frequency, intensity, that kind of stuff, but they don't really break down what they're actually doing. Otherwise they say things such as this, a standard exercise program, which is something I think we need to be a little bit more specific about. But again, that's a topic for another day, but something to look for when you're reading these studies or looking at them. What are they actually doing? So what this study is they broke down. They had a bunch of patients, and they broke them in, and they tried to find 5 clinical factors that were predictive of benefit from cervical traction. And they took a lot of these people, and they had their inclusion criteria, exclusion criteria. And what they did was they wanted to try to find the people that really fit into the subgrouping category, that really fit into the cervical radiculopathy type of symptoms, right? So there were 5 clinical factors. One was peripheralization of symptoms with lower cervical mobility testing. 2 was positive shoulder abduction sign, which is essentially you put your hand on the top of your head, and if you do that and symptoms go away, then it's a positive sign. 3 is positive manual distraction test. 4 is positive upper limb tension test. And 5 is if your age is greater than 55 years old. So this subgrouping criteria was found positive if 3 or more factors were present, and then negative if 2 or fewer were present. So So that's essentially the subgrouping for the cervical traction, for the mechanical traction, and then so people got put, if they got positive in that, they got put into that treatment group. Individuals who met the inclusion and exclusion criteria overall were placed into one of 3 randomized treatment groups. So again, like the title says, exercise alone, exercise with mechanical traction, or exercise plus over-the-door traction. Follow-up assessments were taken at 4 weeks, 6 months, and 12 months after enrollment. So pretty long period of time here that we were really able to break down and see what was going on with these people. So what were they looking at? The primary outcomes were neck disability index, and secondary outcomes were neck pain and arm pain. Both of these were put on a numeric pain rating scale 0 to 10. So results. The results showed that for the neck disability index, a lower score was found in the mechanical traction group after 6 months, and a lower neck disability index score persisted at 12-month follow-up in the mechanical traction group compared to the exercise group. Results for the secondary outcomes found lower neck pain intensity ratings in the mechanical traction group compared to the exercise group at 4 weeks and compared to the exercise group and over-door traction group at 6 months. Overall, the results generally favored the traction groups relative to the exercise group, but they failed to reach statistical significance for the primary analysis at the 4-week, 6-month, and 12-month follow-up. So essentially what that means is taking everything into consideration, adding some cervical traction to a standard exercise program for patients with cervical radiculopathy resulted in lower disability and pain intensity ratings. There is some validation of the subgrouping criteria for people with cervical radiculopathy, but the magnitude of this effect wasn't that large. As I said before, it wasn't found to be statistically significant, but overall, this subgrouping category, you should use traction with patients who present with cervical radiculopathy regardless of the subgrouping status. Now, one of the reasons why we need to take these findings, a little bit lightly is because in this study, there was a large rate of loss to follow-up, which may have biased the results because they use what's called an intention to treat analysis, which means regardless of whether if people left the study or not, they still kind of included them in their overall results. It's a statistical way to sort of keep all your scores up to snuff, I guess you could say. For those not too involved in the statistical realm, what that does is it keeps your beta high, and it reduces the likelihood of a type 1 or type 2 error. So something to take it with a little bit grain of salt. As with every research, nothing's perfect, but again, these are sort of what the basic ideas. Again, just simply, there's some validation for subgrouping people into cervical radiculopathy with the above clinical factors that I had mentioned. But overall, if someone does present with any type of cervical radiculopathy, neck pain, with arm pain, traction was found to be somewhat beneficial, at least in the long term. And this was a good thing about this study, was they had a 12-month follow-up for people. So, you're really able to track them over a long period of time. Now, I know you wish you'd like to see, a 2-3 year follow-up, but, we'll take what we could get. So, pretty good study overall. I think, again, going back to the patient case, I think this would be somewhat beneficial for this person. It's one of those things where it doesn't really hurt to try. As long as you rule out a lot of these sort of red flags that Corey had discussed before. If you rule out a lot of these red flags, then doing some mechanical traction may not be a bad thing to do. If you're strapped for time, maybe it's something that you do. You put them on a modality, and then you're good to go for whatever it is, 10 minutes or so, and then you could come back to them. So it's a good kind of way to throw it into the treatment plan. What do you think, Corey, about the relating all this back to the patient case?
Yeah, I agree, and I think that's there's evidence there's evidence for attraction is the bottom line. Is it strong evidence? Not necessarily.
Right.
I don't know if there's strong evidence for a lot of stuff, but I would say there is definitely enough evidence to try it.
Yeah.
It's definitely something when I have a cervical radiculopathy patient, especially someone who maybe isn't so acute that they're like really irritable and really jacked up, then oftentimes I am thinking about cervical traction with those patients.
Right, and something I actually forgot to mention was that, you have to take into consideration with this study is that they lumped exercise in with everybody, right? So everyone did some sort of standard exercise program with sort of mechanical traction put on it. So if you really wanted to, I guess, find whether this was of true benefit or not, then you would, maybe have only a cervical traction group, or just like a control group, that just didn't really do anything. So it's, again, like you said, it's a study that sort of points towards mechanical traction as being beneficial, but agree with you that there are other studies out there that say, hey, it's not really that beneficial, and just do some exercise for them.
Mm-hmm. Yeah, and again, just to kind of give some take homes from my article in regards to this patient, they did advise traction, especially more in the chronic phase. So again, traction for this patient is something that I would consider using. They talk about mobilization or manipulation when appropriate. To me, again, if you're gonna manipulate, you better be at least doing your test to rule out a lot of those major issues. You're ruling out ligamentous instability. You're making sure they don't have red flags. Doing blood pressure and vital signs on every single patient, especially every cervical patient I'm manipulating. And you're getting, especially if they have a headache, to me, again, this wasn't really a big focus of the day today, but headache is something that I'm going to go ahead and question about quite a bit. What's the nature of their headaches? Are they, where are they specifically? We know that the suboccipital muscles tend to kind of refer over the eye, so I'm okay with that. And a lot of times, even with suboccipital ones, you can kind of reproduce it with palpation. Mm-hmm. Are they getting any strange headache symptoms? Obviously, we know about the thunderclap headache, right? They probably wouldn't be sitting in front of you, in no apparent distress if they had that. But you want to get a sense of are those headaches getting worse? Are they getting better? So you can feel confident that it's a musculoskeletal based headache.
Right, and then it's definitely, Corey, you are better equipped to speak of this than I am, but with those headaches, right, you're talking about some vestibular type people as well.
Sure.
So, you gotta rule that stuff out. It's headaches are a very tricky type of diagnosis to use, especially when you're a physical therapist and you're thinking more of like that suboccipital type of headache that you were discussing, Corey. I've seen a good amount of post-concussion syndrome athletes who, trying to get them to discuss headaches is a very difficult issue, right? Trying to talk about frequency, duration, what type of headaches, all that kind of stuff. So it's really difficult.
They don't know and they don't care, right? They're like, yeah, whatever, just get me back.
Exactly. They just want to get back to playing, yeah. So.
Right. But I'll tell you what, my advice, if you're unsure about a headache, about where it's coming from, first do a nice, what I would call a vestibular eval, or let's call it at least a cranial nerve exam. You want to look at their oculomotor movements, give them a head thrust or a head impulse test. You want to see if anything is coming up vestibular-wise. Yep. If that's all pretty clean, and let's say you're still pretty unsure, that's not a bad time to refer out.
Yep. And that's a good way to sort of get that trust of the local physician community as well. You've done your due diligence and you've sent them out. One of the big reasons why physicians are so, I don't want to say scared, but they're so nervous about direct access in a lot of cases is they think that a lot of these people will slip through the cracks. So, if we're able to be good referral sources for physicians, I think that would very much improve our cause and in becoming more of a primary clinician to go to.
For sure.
So
once again, take homes. with these patients, Sperling's upper limb tension test, distraction test, and you're looking at what sort of symptoms do they have. This patient case, she had symptoms down the top of her shoulder, her lateral arm, and down to the thumb side of her hand. That's looking like C5, C6. That's one of the most common areas you're going to find radiculopathy. And I didn't give any information about reflexes. I'm not actually sure off the top of my head, but you're going to look at reflexes, C5, C6, C7, C6, C7, excuse me.
Mm-hmm.
And you also want to look again with each patient, what's the mechanism of injury? If there is none, that's one thing. If they had a serious car accident, that's another thing. You're going to want to look at pain catastrophizing or kinesiophobia, maybe even PTSD. Maybe this patient is just terrified of movement at this point. A lot of education for those patients.
Something I want to throw my hat into the ring as well with all this stuff is look at thoracic spine.
Yes.
Because that, I believe, is very much left out a lot of times, and it's not thought of. But get some spring testing going of the thoracic spine, see how it's moving, especially if they have that increased thoracic kyphosis. It's not moving that well, which essentially leads to a lot of stress going up the chain into the neck. So definitely check out thoracic spine. Again, what Corey agreed. Reflexes, especially whenever reflexes, no matter what, if you have any sort of spine related issue, I think reflexes are very important to rule out, especially if you have any sort of radiculopathy, cervical, lumbar, whatever it may be. Reflexes for sure.
Certainly.
But I think that's a pretty good breakdown of cervical radiculopathy. Corey was able to talk about some diagnostic type things, some C-spine, nexus. I love it. I broke down a little bit of some treatment stuff. Mechanical traction seems to be beneficial. I'm not going to give it a hard A, right? But a C will do. A C will do. So very good. That's it for today. A little bit shorter than usual, but that's okay because we have a little bit of an interesting episode coming up next week. We'll do a little prelude for it. We will be having a debate. Corey and I, we will be debating on what else but dry needling.
Hot topic.
Such a hot topic in physical therapy right now. What does it do? What doesn't it do? When should we use it? When shouldn't we use it? Should we be using it in general? You'll just have to tune in next week for Corey and I to break it all down, take the gloves off a little bit. And
right. Your Dukes, Dave.
Put them up. So that's what's going on next week. We are super excited for it. Can't wait to bring that to you. But in the meantime, we hope you enjoyed this episode on cervical radiculopathy. Hope you got something out of it. Any questions, comments, concerns, please leave it for us. You can reach it through the comment section on our Facebook page or even on the YouTube page. So hope you all enjoyed. Have a great night. We'll be back with you soon. PT Forensics.